University of Washington Addictions, Drug and Alcohol Institute. Thank you so much for joining us today for our webinar, What's New with Naloxone. Today in the webinar, we have two great presenters, Chelsie Porter with the Washington Department of Health and Sharon Stancliff, MD, with the New York State Department of Health. We put together this webinar because we wanted to answer all of your questions about naloxone, or as many of them as we can in an hour. So thanks to everyone who sent in questions, just in general, and just everyone for being here today. So just to orient you, we are using Zoom webinar, which means participants can't share their screen or audio. Please enter your questions in the Q&A or the chat. If you're a journalist, let us know if you plan to report on this webinar. It's just helpful for us to know and to be aware. And just please be respectful and be curious. So as questions come up, if it's a clarifying question, we'll have our presenters answer it. If it's like a larger, broader question, we'll hold those to the end. But please, use the chat to sort of ask questions of each other, and the Q&A to sort of ask questions that you want to make sure the presenters answer. So I'm going to go over and hand over. Sharon should be able to control the screen. I'm going to let Sharon introduce herself, and I really just want to say thank you so much for being here with us today. Really appreciate you taking the time.
Well, thank you for inviting me. I'm glad to be here. A little bit about myself. First of all, I got my bachelor's at the University of Washington, so I wish I was. I'm currently the Associate Medical Director for Harm Reduction and Healthcare at the New York State Department. We have an Office of Drug User Health. And I'm also still in practice a little bit prescribing buprenorphine in a shelter. First part of what I'll present is work that I did with the New York State Department of Health very recently. Last part of what I present on rescue breathing and chest compression back when I was the medical director. So,
Sharon, your audio is cutting out again a little bit. So I guess just speak loud.
Okay, how's this?
Great.
Okay.
Thank you.
So a little overview, we're going to talk about naloxone dosing, the 8 milligram versus the 4 milligram formulations, and then look at some really great work from Pittsburgh, the Prevention Point Pittsburgh, on their use of the intramuscular 0.4 milligram, and then talk a little bit about some work that we did on how we should train people to do resuscitation when they have a suspected overdose. So I promise this is the most complicated slide I'm going to show you, but I think it's good orientation for when we're looking at naloxone doses. Top line here is one spray of the 8 milligram product that's out there, and you can see the plasma concentration is up over 8 nanograms per ml. The bottom line is the 0.4 milligram IM injection, which is where we began when we first started distributing naloxone in the community. And then in between, you can see 2 milligram formulation, which isn't currently on the market. That's the next one up. And then the other two are 4 milligram, 1 spray versus 2 spray. So this is just here to give you a sense of what the variation is in terms of both plasma levels, how high they are, and how long they last. There we go. So first I'll talk about the study that we did, or the pilot that we did in New York State. We've worked with law enforcement for a long time. We supply them with, first we gave them the old put it together yourself 2 milligram naloxone, which is a lot weaker than the 2 milligram we just looked at. And then when the 4 milligram came around, we did a study comparing those two to see if we saw differences, primarily in the occurrence of withdrawal syndrome. We not only didn't see a difference, maybe a trend, but we didn't see a difference in the likelihood of significant withdrawal systems between the old 2 milligram and the newer 4 milligram, but we also didn't see a difference in doses, number of doses, and that was interesting because they are trained to wait 2 minutes between doses. So since then, they've been using the 4 milligram per 0.1 ml intranasal dose. As I think you know, the FDA approved the 8 milligram intranasal naloxone product in 2021, and we decided that we would do a pilot comparing them using our New York State troopers because there wasn't any literature out there. So we wanted to compare the two and see what we saw about post-naloxone dosing symptoms between the two. And you can see our data brief at that address, and we are preparing to submit something to a peer-reviewed journal. So starting in March of 2022, we gave 3 troops of New York State troopers the 8 milligram dose, and the others continued to receive the 4 milligram dose. They have a long history of submitting reports for each administration that ask a number of questions. Exclusion criteria were if the opioid toxicodrome was not present. Sometimes that was pretty clear from reports, and we actually went and looked at some body cam footage at times. That was if multiple naloxone formulations were used, for example, there was somebody from the community and then somebody showed up from EMS, and if it was determined that the person being aided was deceased before naloxone. The average number was compared to the t-test, and then we looked at a variety of post-naloxone syndromes and hospital transport with relative risk. So between March 1st, 2022 and August 16th, 2023, we had 354 reports meeting inclusion criteria. 101 of these were 8 milligram naloxone. We had decided to actually cut off at about 100, and 253 were 4 milligram naloxone. First and foremost, there was no difference in survival, which is the main point of all this, of course. And then interestingly enough, the average number of doses administered between the 4 milligram and the 8 milligram did not differ. There was 1.58 for the 8 milligram dose and 1.67 for the 4 milligram dose. And these officers, both groups, had a retraining asking them to wait between doses. I know, having reversed overdoses myself in the field, it is scary to wait the 2 minutes, so I can't guarantee that they did. But I suspect that this is probably a marker for what most community people do. Minutes feels really, really. So this is what we found, and you can see the various components or indicators that we looked at. We saw no significant difference between the perception of anger or combativeness on the part of the police officers. Sometimes when we looked at body cam, that was kind of, they look angry. So this was their perception. We did see a difference, but it was not significant in the number of people refusing transport to the hospital, with about 26% of the folks on the 4 milligram and 19% of the folks on the 8 milligram. It's a trend, but it is not significant. No difference at all in survival. As far as we were able to determine, these folks were not dead before they arrived, but we couldn't always tell. No difference in withdrawal symptoms, at least at the significant level. I'm sorry, I just went off. This is where it's significant. Forget what I just said. There was a significant difference in withdrawal symptoms, which included vomiting and a few other things, not just simply runny nose. But again, it was the police officer's perceptions. So 19% of the people receiving the 4 milligram naloxone had withdrawal symptoms, while 37.6 of those receiving the 8 milligram naloxone did. And so this was a relative risk of 2.51. Vomiting, there was no significant difference, perhaps a trend towards more vomiting among the 8 milligram folks. Disorientation, no significant difference, and lethargy, no significant difference. So this not terribly surprising to see a difference in withdrawal symptoms, although that surprised us in the comparison, the first comparison we did of 2 versus 4. No difference in the number of doses. So this, I think, striking part of this. No difference in survival. The no difference in doses suggests that extra dosing was probably unnecessary, and we'll look at that a little bit more when we get to the next work from Pittsburgh. Significantly higher risk of post-naloxone withdrawal symptoms administer 8 milligrams. Now, it's better to have withdrawal than be dead. Big picture. But we don't know a lot about what the unintended consequences of that might be. Are people more likely to use again immediately? Might they be less likely to want to use naloxone in the community? We don't know. And the one that concerns me the most as a physician is vomiting, because aspiration of vomit is dangerous, and you don't see the impact of that until well past the time that they're under observation. That takes a day or 2 for aspiration pneumonia to develop. I've seen some concerns in the literature of post-overdose respiratory complications. One of the papers that I read pointed out that might have become more common when it became so easy to go bang, bang with 2 doses of the 4 milligram, whereas the injectable and the previous 2 milligram, you had to do a little work to assemble it. So you gave folks a moment to onto it. Some of these are not questions that we can answer, but I'm glad that we have a little data comparing the higher dose and the lower dose at this point. So now I'm going to turn to Prevention Point Pittsburgh, which is a program that I really love. Here's some pictures from them, and you can see they do a lot of work. They've been around for quite a number of years, but the key point here is they've been distributing naloxone since 2005, and one thing that's really great about them is that they have people that come back and tell them what happened. They have a whole lot of people that come back and tell them what happened, which not a thing that we see even in needle exchanges in New York City. We're out in the street. People come and go. It's hard to collect this kind of data. So they've been distributing naloxone since 2005. In 2022, they had distributed over nearly 14,000 people had received naloxone, and they had large number of people, 5,971 people returning to say that they used the naloxone. Early on, they were really only distributing naloxone at their syringe exchange sites, so those were primarily people who used opioids. They expanded a bit, but 89% of the naloxone rescues were performed by people who use opioids. Really a great program, and I'm sure you've got them in Washington. So what did they see over time? This is a published study that looked at naloxone dosing between 2013 and 2016. 2013, very little fentanyl around, and the average number of doses was 1.62. 2016, 68% of the fatal overdoses involved fentanyl, but their rate was 1.52. They have continued to collect data, and I really want to find somebody that was going to publish this again, but they shared it with me. In 2020, 95% of overdose deaths there involved fentanyl, but their mean doses per reversal stayed at 1.52, and we see the same thing reflected in 2021, about the same amount with fentanyl, and the average number of doses is 1.64. So remember that slide I showed you at the beginning? This 0.4 milligram injectable has extremely low plasma levels, compared to what's a standard dose is the 4 milligram 0.1 cc dose, and just infinitely lower than the 8 milligram. So, we really want to respect the needs, comfort of the folks in the field that we're administering naloxone to. So at this point, Prevention Point Pittsburgh offers both the 4 milligram 0.1 cc and the 0.4 milligram per cc. Not a choice. Half of them request the injectable, and reports have reversed someone else's overdose. But sometimes people come in that have received the naloxone themselves and report multiple doses of the 4 milligram, making them sick. So they ask for the 0.4 milligram injectable. Now, they also have no reports of anyone coming in saying, I think if I'd had more naloxone, it would have been different. That's a pretty hard thing to determine, but that's not what they're hearing. So I was asked to comment a little bit on overdose response in the time of Xylazine, since Xylazine is parts of the country and becoming really common up and down the East Coast. Xylazine, of course, is a veterinary anesthetic or analgesic muscle relaxant anesthetic that causes extreme sedation and extreme muscle relaxation. So we've looked again at some of our guidance on overdose, and I won't go through all the guidance, but it's administer naloxone, call EMS, whichever is easier to do first is what you should do first, and then resuscitation efforts. Now, we'll talk about rescue breathing versus chest compressions in a few minutes, but whatever you choose to do or not to do, make sure that airway is opened, because if the respiratory drive is there and they're so slumped and their tongue is in the way and the respiratory drive isn't that strong, the air is just not going to be able to get in physically. So after any dose of naloxone, check back for breathing and response. Responding to pain when they didn't before, when they did again, making sure that they can get air in. I know it's hard for lay people to check for breathing, but checking for groaning when you cause pain is a suggestion that they're breathing. Some needle exchange personnel, et cetera, have pulse oximeters. Those can be helpful. Rescue position when you know they're breathing, as vomiting may be more likely with Xylazine. All of our studies on Xylazine are essentially animals. I can tell you trivia, like used as an emetic in cats, so it makes cats vomit. I don't know about humans. And then remembering that they may be sedated for some time, please call for help in these heavy sedations. But if not, sure they're not so sedated. Make sure that they're not putting huge amounts of pressure on their skin and nerves. I don't know if my recent patient had Xylazine in his heroin, but he passed out in a awkward position, and he ended up with wrist drop because the nerve. It's a couple months later, he's now able to lift his wrist. This can't extend it. So this is a real concern. It's not a new problem. We've seen that for a long time. It's been a sort of standard with alcohol and intoxication. So now to turn to resuscitation for a couple of minutes. The question of rescue breathing versus chest compressions became pretty heated back in 2015 or so. I was at a time at the Harm Reduction Coalition. I was hearing from the American Heart Association, you shouldn't be teaching rescue breathing alone. I was hearing from people in Canada that this was an awful thing to do, but other people were saying this is what they need, so this is what we have to do. Don't even talk about chest compressions. So we put together a working group, and the document remains online, and I believe it's still up to date. I've been following the literature pretty regularly but loosely since then. But to determine what resuscitation techniques should be taught by overdose prevention programs, not necessarily what people should do, but where should we put our energy. Had participants representing harm reduction, emergency services. I got my favorite cardiologist to come, primary care, and substance use services, mostly from New York, but we had some folks from California as well because they had such expertise in it. I don't want to dwell on the small points, but it was fascinating. In the morning when we gathered, a bunch of people were like chest compressions only, half were we got to do rescue breathing only. We broke for lunch. It was almost like everybody had flipped positions. And so it took a while to figure out what to do. But part of it was thinking about who is offering naloxone training. Of course, the harm reduction world is doing, and that's addressing people who are pretty likely to be able to identify an overdose accurately, although nobody can be sure why somebody's unconscious. Law enforcement, people with exposure to people use opioids both illegally and for pain, but with very little experience with opioids. We've got standing orders. I do the standing order for the state of New York. What are we going to tell pharmacists to tell people? And then people attending CPR and first aid training courses. So there's others. It's a really diverse bunch of people that are getting trained to use naloxone. So what do we find? First of all, we determined that administration of naloxone and calling EMS are the absolute highest priorities in a way that's similar to if you've got an AED, use your AED really fast. Because painful stimulation has a role both in assessing an overdose and it might induce some respiration through a different mechanism, that step, painful stimulation, chest rubs, or whatever you do in Washington State should be emphasized in training. And then, well, Philip Coffin put it well, we're in a data-free zone. We said, if there's insufficient data to recommend one resuscitation method over another, clinical directors, it was based in New York, we have clinical directors, will need to determine whether rescue breathing, chest compressions, both, or neither is most appropriate for inclusion in rescue breathing, for example. My personal opinion is that's really great when we've got syringe access programs. Chest compressions is something that, well, I'm going to go through some of that, but I can't ask pharmacists to teach any of these. They are so busy. It's great if they can make sure somebody knows how to recognize an overdose when they give naloxone. So I pulled a few points regarding rescue breathing and chest compressions out to consider. The potential benefits of teaching rescue breathing, and so maybe people will do that, is that's probably more beneficial for people actually having an opioid overdose as opposed to those who are experiencing a sudden cardiac arrest. In overdose, your blood is depleted of oxygen. It happens slowly. But sudden cardiac arrest, chest compressions actually have some oxygen to push around. And it's most important, if naloxone is not available and EMS is either not called or 20 minutes away, which happens in rural places, some urban places. Potential problems, the medical literature on learning and retaining skills on effective rescue breathing is really challenging. People have a hard time learning it, and they have a hard time retaining it. And poorly done rescue breathing may fill up the stomach and increase the risk of aspiration. That's a concern. Points regarding chest compression. It addresses cardiac arrest, which may have happened. Possibly some passive respiration. It was hard to find good data on that. Potential problems, of course, in an opioid overdose, the blood and organs are depleted of oxygen, brain in particular, that in there. And there's actually no data on the effectiveness of chest compressions only in the setting of overdoses. There's a ton of data on its effect in cardiac arrest while awaiting EMS, but none in the setting of overdoses, and I can't see any way we'll get any. Teaching both, that would be great. I mean, we teach people that are leaving prisons in New York how to administer naloxone, and they can get it when they walk out the door. That's a program for New York State Department of Corrections. Wouldn't it be wonderful if they all learned full CPR too, equipping people that have been incarcerated to save lives, I think is a really aspirational idea. It's like they're entering with some skills and teaching neither. There's a lot of settings where spending a lot of time teaching either of these might reduce the time in teaching about the recognition of overdose and the administration of naloxone. So our conclusion, let me see if I have a slide on that. Our conclusion is that programs need to look at what their participants are able to learn and able perhaps to do in the field. There's not a cut and dried answer. Now I want to acknowledge a few of the people that I've been working with: Emily Payne, Kristen Rowe, Michael Daly, and Sergeant Jason Christie was our representative from the New York State Troopers. And then Alice Bell from Prevention Point Pittsburgh gave me the data. Actually, she gave me the data from 2022, but it was still raw, and I didn't have time to look at it. My great thanks to them. And I think we'll probably hear from Chelsie next, but I look forward to your questions, comments, complaints. Thank you so much.
Thank you so much, Sharon. I'm going to go over and hand over control of my mouse to Chelsie. We do have a few questions in the Q&A that Chelsie might answer, and after Chelsie's piece, we'll open it up to more questions. So keep putting those in the Q&A and definitely add anything to the chat that you want to. So I'm going to hand it off to Chelsie.
Thanks, Allison, and thanks, Sharon. That was super helpful. I don't think I can share my video, which is okay. People don't need to see me, but just know that I am here. My name is Chelsie Porter. I use she, her pronouns, and I am the Syringe Service Program Coordinator here on the Drug User Health Team at DOH. And our team helps support syringe service programs, other drug user health services, as well as the overdose education and naloxone distribution program. So I'm going to tell you all a little bit more about naloxone access in Washington State. And I do see a few questions in the chat, some of which we'll cover. So maybe, Allison, I can do this presentation and then we can chat more about any questions that didn't get answered. So we today are going to talk about over-the-counter naloxone. We're going to talk a little bit about the current Washington State standing order to distribute naloxone, to dispense naloxone. And then we will also talk about where individuals in Washington State can get naloxone, as well as organizations where they can get free naloxone. So to start with over-the-counter naloxone, I just want to start by saying this is very new. All of the over-the-counter approvals have happened this year. Things are definitely still changing in the space. So I will talk a little bit about what we currently know and what we're expecting. And then if there are any questions that are unanswered, we can follow up later. Or if there are folks on this call that have additional information, I absolutely welcome you to provide that as well. So as many folks probably have heard, Narcan nasal spray is a 4 milligram naloxone nasal spray that was approved for over-the-counter use in March of 2023. As of right now, Narcan is available at major pharmacies, and we expect it to become available in more places as time goes on. The current pricing for the Narcan nasal spray is about $45 to $50 per 2-dose kit, as I've seen it on shelves. I just want to note, too, that there is another nasal spray product that was approved. It's called Revive, and it's actually a 3 milligram nasal spray. And we're expecting that to hit the market in early 2024, although it's still unclear where that will be distributed. We know that, $50 for a 2-dose kit is not accessible for many people. And the good news is that the Healthcare Authority has said that the Washington Apple Health or Medicaid will cover over-the-counter naloxone for free. There's a prescription. You'll still need to have a prescription for it, either a prescription from a provider or the Washington State standing order, which we'll talk about. So we're still figuring out exactly the mechanics of how folks can get that naloxone for free as an over-the-counter product, but want to let people know that hopefully that will improve access to this over-the-counter product. And thank you to Allison and to the folks at ADAI. They did develop a webpage at stopoverdose.org, which has more information, including frequently asked questions about over-the-counter naloxone. So I imagine that will continue to be updated, and as we learn more, we will share information there. Next slide, please. So for everybody's reference, DOH has created and has been in place for a while a statewide standing order to dispense naloxone. This statewide standing order to dispense naloxone does a couple of things. Very importantly, the statewide standing order essentially acts as a personal prescription to get naloxone from the pharmacy. So if you do not have a doctor or you do not want to go to your doctor to get a prescription for naloxone, you can take the statewide standing order to the pharmacy and use that as your prescription. It is free with Medicaid or Washington Apple Health, and it is covered by other insurance plans, but that coverage often has, varying levels of coverage and varying levels of copays, which may or may not be accessible for folks. I will mention that we did include both the 4 milligram nasal spray as well as a 0.4 milligram intramuscular naloxone, but I don't know of any pharmacies carrying the injectable formulation. So by and large, if you're using the statewide standing order to get naloxone at a pharmacy, you will get the nasal formulation. Another thing that this standing order does is that it enables organizations who want to distribute naloxone to use that standing order as their prescription to get and distribute naloxone. And many of those organizations are getting naloxone from our overdose education and naloxone distribution program, which I'll talk about soon. On our webpage, which I can put in the chat, we do have both a link to the standing order and frequently asked questions about the standing order. So those are good resources for folks. And if you go to the next page, Allison, I'll show that standing order. Here it is in all of its tiny font. It is very hard to read here. But this has the different formulations of the standing order. It has information about who it can be distributed to, which is anybody that is at risk of experiencing or witnessing an overdose. It has some terms and conditions on here. Just want to note for people that in my experience, I always bring the standing order to the pharmacy with me, either on my phone or printed out, because very often I find that either pharmacy techs or pharmacists may not be immediately familiar with the standing order and will want to see it. So that is a good resource for folks, and we're definitely encouraging people who have insurance, who have pretty good coverage for naloxone, to access naloxone at the pharmacy as a sustainable resource. And go ahead, Allison. And I just want to note on the standing order, the standing order doesn't have a limit on the number of kits. Oh, excuse me. I think it's up to 5 kits per visit to the pharmacy that you can get. Medicaid has said that there's no limits on refills, to my understanding, so people should be able to access, a sufficient quantity of naloxone from the pharmacies in most cases. However, we do know that pharmacy access of naloxone can be really limited for people. Like I said, there's a lot of misunderstanding about the standing order, I think, among pharmacists and community alike. And the cost can still be prohibitive, especially for folks who have copays or who are uninsured. So we want to make sure that people also know that there are lots of access points throughout Washington state where individuals can access naloxone for free. One really important resource for people who use drugs and community members and families and friends that we have in Washington state are syringe service programs. Syringe service programs provide a wide variety of services and supplies for people who use drugs, including naloxone. And every SSP in Washington state distributes both injectable and nasal naloxone for free. And I'll show you a map of those programs in just a moment. And then I also want to call out that we do in Washington state have a statewide mail order naloxone program. That program is provided by the People's Harm Reduction Alliance, which is one of our longstanding syringe service programs located in King and Kitsap counties. So that link right there, prod.org/naloxone, you can go on there and order naloxone by mail for free. And we really want to emphasize that this program is intended to serve people who have limited access to naloxone. So people who don't have good pharmacy access in the area, people who don't have insurance, people who have really high copays. This really is intended to be a safety net program and not an on-demand naloxone program, because we want to make sure that we have enough resources to support the program for people who really need it. But if you're working in community with people who are needing naloxone, particularly if you're working in rural areas or areas where naloxone access at the pharmacy may not be realistic, please do feel free to share this program widely, and people can get naloxone that way. Next slide. Thank you. Here is a map of current syringe service programs, and I want to mention that this is absolutely not all of the programs in Washington state that are distributing naloxone, but as you can see here from the little dots, we have syringe service programs in nearly every county in Washington state, and many of these programs have multiple sites throughout the county. So you can take a quick peek, see who might be in your area, might be close to you, and if you are wondering, if you Google Washington Syringe Service Program directory, there's also the list of the certain service programs in your area where you can go to get free naloxone. So that pretty much covers how individuals in Washington state can access naloxone. If you represent an organization that would like to get free naloxone, DOH has a program for that. So DOH's Overdose Education and Naloxone Distribution Program provides free training and technical assistance around overdose response. And we also provide free naloxone for distribution to people who use drugs, their families, and friends. So any organization in Washington state that works with people who use drugs can apply to the program and get free naloxone to distribute directly to their communities. I did see in the chat that there is a question about organizations that want to get naloxone for their staff to carry. This often comes up in the context of police departments or first responders. So I wanted to mention that with certain exceptions, naloxone from our program must be distributed to community members. It can't be used for staff to respond to overdoses. So it can't be used, for example, for a police department that wants to order naloxone for their officers to carry and respond with. We do, because of some new funding that we got this biennium, have the opportunity to provide kits for agency staff at a couple of different types of organizations. So syringe service programs, street outreach programs, shelters and permanent supportive housing programs, as well as community behavioral health agencies, are all eligible to apply to the program to receive naloxone for their staff to carry to respond to cases of overdose. So that's been a bit of an expansion. I just want to mention that we also have a separate funding set aside for tribes, tribal organizations, and urban Indian health organizations. So programs affiliated with a tribe or an urban Indian health organization, there's a different application for that. And we can provide free naloxone, both for agency use and for distribution for those partners. And we, as I mentioned, also provide community trainings. So depending on where you're located, either the Department of Health, our team at DOH, or possibly your local county health department can provide free overdose response and overdose prevention trainings, including naloxone administration. So if you are an agency that is interested in getting a naloxone training, please feel free to reach out to us at naloxoneprogram@doh.law.gov. Sean Hemmerly will respond to you and help you coordinate that training. And those are all free, as I've said. And if you have any questions about certain service programs, about naloxone distribution or our program, please don't hesitate to reach out. We are super happy to hear from folks and really happy to help provide resources wherever we can and help connect you to other resources if we're not able to provide them.
Thanks so much, Chelsea. There's a few questions in the chat that I think I'm going to hand off to you, and then we'll open it up more generally to questions. Carly Hood asks, can minors use the standing order to access naloxone?
There is no age limit or minimum age requirement on the standing order.
Let's see. Other questions. Oh, is the injectable dosage of naloxone available to the public in Washington?
Correct. So the injectable formulation of naloxone is on the standing order. So people can, it's covered by the standing order to distribute or to administer. Like I said, most pharmacies don't carry the injectable formulation. So if you want the injectable formulation, your best bet would be to go to a syringe service program or another community access point, or you can request intramuscular injectable formulations through the statewide mail order program.
Next question for Chelsea. Does the limit of 5 kits also apply to SSPs or only for pharmacies?
Great question, Rachel. Thank you. That limit of 5 kits only applies to dispensing at pharmacies. So community organizations can, and we encourage them to, provide as many kits per interaction as people request.
And Chelsea, let me know if you want us to try and get your video turned on or if you're okay with no video.
That's okay.
So, okay. Next question that is Chelsea specific, and then I think we can move it into the more general ones. What do we do with our expired naloxone?
Good question. So first and foremost, there is good evidence that naloxone is effective. We have way past its expiration date. We have one study that shows that it had almost all of its effectiveness 30 years past its expiration date. So first and foremost, don't throw your naloxone away. If you do have policies and procedures at your organization that restrict you from distributing or using expired naloxone, please feel free to reach out. We have lots of orgs that might distribute it. We have orgs that might use it for trainings, and we might use it for training. So bottom line, don't throw away your naloxone. Reach out to us and we can help you make a plan.
And then I think I have one more question that is maybe Chelsie specific. I am deaf, hard of hearing, and speak using ASL, and I am trained trainer for naloxone. How can I help make an ASL training for deaf?
Wow, David, this is a wonderful offer. Thank you so much. I actually just talked to somebody in King County who was looking for a deaf and hard of hearing resources around harm reduction specifically. So if you, David, want to email us, that would be awesome. We would love to talk with you about how we can create resources. And Allison, I don't know if that's something at ADAI that y'all might be interested in have resources for, but I think between all of us, we can figure out a plan to develop some training capacity in that area. So thank you so much.
Yeah, I think we could
And
if we
I
did.
would like to.
Oh, sorry, Sharon,
I
go
would
ahead.
like to. I'd like to be hooked into that. I think that's a really great idea. So
Thank you.
A lot of these are Washington specific. Is the standing order available for those with non-opioid use disorders, such as methadone use for restless leg syndrome or low-dose chronic pain, neuropathic pain issues? Thanks.
Yep. So for the standing order, you don't need to give a reason. You don't need to have a diagnosis. You don't need anybody who can experience or witness an overdose can get naloxone using the standing order. And considering the number of overdoses we're experiencing every day in Washington State, safe to say that is everybody.
And it looks like Emily Hurio shared an ASL training resource, which I'll also put in the chat for everyone to see. Love all this resource sharing and creativity here. This is great. And I have a thank you for answering the question on expiration. The information is great to know. So yeah, I think it's really effective medication and it's really effective for a long time. So going back to more questions that either of you could answer, why is Revive only 3 milligrams in comparison to 4?
I am very glad to see a 3 milligram product out there. Honestly, when the company that makes the 4 milligram first made it, they came up with a 2 milligram that I think I would have really liked. I think that the data that I showed suggests that even the 4 milligram might be too high given the amount of vomiting that we saw. I think it was 20% with the 4 milligram. You know, I can't speak for what plans we'll make at the New York State Department of Health at the collaboration, and we haven't begun to address the 3 milligram, and I don't know who they're going to make it available to. But I probably wouldn't put it on our standing order without doing a pilot as we have done with the other ones. But I'm excited to see it. I think it might be kinder and gentler towards the people that we are trying to take good care of.
Yeah, I think at DOH, our team is excited to see it too. And we would definitely love to see your pilot data, Sharon, whenever that's ready.
Well, yeah, there's a lot going on in drug user health in New York, but that's hard to doing that.
And then there were 2 questions I'd received via email that I want to make sure we answer. One was a question about nalmefene / OPV or OPV. I don't know how it's pronounced. It's a new product that's being advertised to reverse overdose. Is there any data on that? Could you give a little overview about nalmefene?
Sure. I also don't know how it's pronounced because we haven't spoken. So it's nalmefene, which has a much longer half-life than naloxone. I've seen various things, but it's somewhere between 8 and 12 hours compared to a couple of hours or less for naloxone. So it will reverse an overdose. I haven't verified it, but I think it may be higher potency than naloxone. But it's hard to compare nalmefene to naloxone, and I need to get back with the person who said it's a more potent drug. But prolonging withdrawal has a small advantage for people that won't go to the ED, I suppose, although we have a lot of data suggesting that very few people die of an overdose, with really a lot of data, when they don't go to the ER and they've just had naloxone. So I think that's what they're basing their plan on. But what will people do if they go into withdrawal for a really long period of time? My population is people that have opioid use disorder. they may seek out more opioids, other drugs to relieve that syndrome. If it starts to be seen in the community, administered by police or by their community members, will people be less likely to call for help? Will they be less likely to administer it? I don't know. And no, it has been tested on blood levels on healthy volunteers. We have no field data on it whatsoever for how it works for people that have people that are using drugs that are dependent or not dependent. And I do not foresee doing a clinical pilot on that at all. Frankly, it frightens me. I'm not speaking for the Department of Health because we haven't discussed it yet. I'm speaking for Sharon, but I'm in no hurry to find out how it works.
Thank you.
Obviously, it makes me a little hot under the collar. I don't have.
Another question I received via email was, we frequently hear the idea that when people wake up after an overdose, that they will be upset or angry or come up swinging. That's sort of a question I hear a lot when I do overdose trainings. Could either of you speak to that? Whether that's a likely scenario or whether this is something that people are concerned about?
So I can speak to that, especially given that we've been distributing. I mean, we've had a law enforcement program going in New York State since 2014. I got it mixed up. Yeah, I think 2014. We don't get very many reports of combativeness or anger, and we have never had a report where that was really scary stuff. We hear anecdotes from EMS actually, but vomiting and diarrhea is our yucky part that you can have when you use high doses. But we just don't get many reports. Anecdotally, I did hear one of somebody reversing his neighbor. I think the reversal was either law enforcement or firemen, and the guy did get really upset and at him. But it turned out that's what this guy did all the time to his neighbor. He hated him. So yeah, people don't feel well. They're not happy. They were, last they knew, they were okay, and now they're awake. Don't know what's happened. Maybe drug sick, but violence is just really not a thing, and I think that's overhyped. And I think police reports are sort of the best for that, because when you wake up and see somebody in a uniform, it's like, oh my God. And we've certainly not gotten any from our community reports, of which we have many. We just don't feel as Pittsburgh does.
I have, Chelsie, is there anything you want to add on that?
Yeah, I think Sharon did a good summary. I think, I would encourage folks to imagine what it might feel like to be in somebody's position who experiences an overdose. You wake up, you may not know what happened. People are surrounding you, people are shouting at you. So we really encourage folks to take a trauma-informed approach to overdose reversal and to consider what the setting looks like. Have everybody else stand back. Have somebody stand a little bit far away, kneel down, get on their level, speak gently, say their name, tell them that you gave them naloxone, tell them that you'll stay with them, and really just care for people in a loving way in that moment, because it can be terrifying. And to wake up and be cared for, I think, will elicit a very different response, even if they're sick, than to wake up in a really scary and, high stress situation.
Thank you. I have an interesting question. I realize that this program is directed primarily towards naloxone administration, but are there any considerations about developing the use of buprenorphine to manage opioid overdose? Perhaps fewer SE, less immediate agitation, possibly less vomiting, just a thought.
Trouble with it is kind of slow. In a pinch, that's good, but it's kind of slow. I mean, the program's developing to administer morphine right after a reversal with that. I totally appreciate the point, but it is kind of
maybe this is more of a Chelsie or me question. Are there any recommendations for youth-specific naloxone training resources? We have a webpage on Stop Overdose about how to talk to young people about overdose. I will dig up that link or follow it up in the chat. It's a lot of the same things that you would use with adults, but we really recommend encouraging young people to get trained to help friends or family members. Like a lot of people, youth don't always perceive themselves as at risk for something, but they may be able to see that risk for other people, or really want to be able to help out their community. So highlighting that as a reason to get naloxone training, just because young people may be even less likely to perceive themselves as at risk for overdose. Chelsie, would you add anything?
No, I think Lace and Lethal is one naloxone and fentanyl and opioid information resource that's geared towards young people. That's out of King County, but you can see it online. Anybody can access it. And yeah, I definitely think there's a real dearth of harm reduction and overdose education that's geared specifically towards youth. So if anybody on this call works with youth and would like to work on something, I think it's a really important and good opportunity to develop some new materials.
And Sharon, are you aware of any in New York State that would generally be useful naloxone education for youth?
No, not really. We're currently tasked with produce naloxone education about very young people, because you heard all over the world that we had an incident of toddlers dying of.
And you're cutting out a little bit again.
Oh, I'm sorry.
Sorry.
So no, we don't have anything specific for training youth. I really like the idea. We are currently tasked with providing something about treating it in children because of a bad daycare incident that happened.
And if other people on this have resources they want to throw into the chat about training young people on naloxone, please add them. There's just sort of a comment. I've heard of some individuals using naloxone on pets like dogs as well. Anything to add?
We've heard of it too, because drug sniffing dogs could conceivably get a snort of it. It works.
Yeah, I can say from my time doing Student Service Program outreach, folks' dogs definitely get into things. And naloxone works on dogs. And I do wish my camera was working now, because there's a really awesome handout from the Indigenous Harm Reduction team that's specifically about naloxone and dogs. And it says naloxone and dogs, they're dogs. They put stuff in their mouth, which I think is adorable. And it has really good and concrete information about how to administer, what the dosing might be, kind of a flow chart. So I will try to get a hold of this handout, because I think it's a really awesome one. But just want to know this definitely comes up with people in like everyday situations, not a ton, but it's important for folks to know that they can protect their animals as well.
And I have a really thoughtful comment from Christina Muller-Shin. I've learned to always do a trigger warning when teaching youth, as I have definitely re-traumatized some kids who had been at the scene of an OD. And when I go straight into the training, it has been hard. So I think that's a really important insight, is to think about who you're training, just warn people ahead of time. I think overdose is so common now. A lot of people have seen an overdose or have know someone who has had an overdose or died from an overdose. So going into a training and assuming that it's a population that has experience with it is probably a good idea. And then question from Peter Materko. Thanks for the feedback. How does DOH notify partners when OEND guidance changes?
Great question. And I see, Peter, I don't think I fully answered your question about law enforcement either. So yeah, first of all, like I said, the OEND program doesn't provide full naloxone for agencies, including law enforcement, who want to carry and administer naloxone, with the certain exceptions that I already mentioned. We are working on a program right now to provide naloxone in kind of limited resource level for first responders in rural counties with the highest overdose rates. So that is in progress, and we'll send out information to local health jurisdictions and to folks that work on rural health. We have a couple other partners that we'll reach out to. There's some EMS team at DOH that also does a lot of work with EMS who we'll share that with. So we are working on increasing those resources. I will say that if any organization is purchasing naloxone directly, you can purchase nasal Narcan from Narcan Direct at a public interest price. And also definitely want folks to be aware that there are generic formulations that are often much, much cheaper than branded nasal naloxone products that I encourage folks to check out to see what pricing can be the best. And we do a lot of purchasing TA on our team, so please feel free to reach out about that. As far as updating folks about changing OEND program requirements, if people are getting naloxone from us, we have a lot of direct communication with partners who are enrolled in the program. Partners who are not enrolled in the program, it's a little bit harder, and we are trying to do better about updating our website presence. Although if you've seen our website, you know we're not doing a great job. So we are hoping to make a lot of updates to the website and including some changes to kind of updates about our program section.
And I see we now have no open questions. Does anyone have any final questions about things going on about naloxone? Really can ask just about anything. Either put it in the chat or the Q&A. And while we're doing that, I'm going to go ahead and share my screen one more time, just to share some resources that we put together. So on Stop Overdose, we have a lot of resources on overdose response, our naloxone map, updates on fentanyl exposure, updates on Xylazine, which I'm throwing out there. We still see it very rarely in Washington State, and this is the webpage where we'll provide that update. The overdose education and naloxone distribution program link is here, and the link for Seattle and King County. If you're there, you can also request naloxone from them, and also overdose response training. So that is all that's on that slide. And let's see, just seeing if there's any. Oh, Christina Muller-Shin says, Chelsie, does it cover using IM on animals, the naloxone and dogs handout?
It does. It covers give rescue breaths. It covers how to give both IM and intranasal naloxone. And I will be the first to say I am not a veterinarian. So if there's a vet on the call who wants to verify this info, that'd be great. But yeah, it covers both formulations and how to administer.
And then we have a question, housing outreach after naloxone and treatment options. Do you mean like, how do we connect people, or could you clarify a little bit more about your question? And then someone says, I may have missed it, but will we get copies of the slides? This webinar recording will be posted. I don't think we've decided about whether the slides will be posted, but the webinar will be posted on stopoverdose.org on our video page. And any final questions? All right. Well, I want to thank you both so much for spending time with us today, answering everyone's wonderful naloxone questions. Thanks for coming in from New York and Washington State.
I hope you'll save the chat. There's a lot of stuff there I would like to link to.
Yeah, we'll save the chat. I think I'll create a resource list based on what people shared, because there's so much good stuff. So thanks. Sorry we didn't have the chat enabled for a little while, but thanks for making it lively once we did get it up and going. So thank everyone so much.